Bismillahirrahmanirrahim. Good afternoon, everyone, and welcome to the Egyptian Mafld Research Group session on the last day of the ADDW 2021. I'm Professor Dina Atiyah from Beni Suef University. I would like to start by thanking the organizing committee and especially Professor Suraq Zakaria for his kind invitation. In this session, I'm pleased to introduce Professor Yasser Fouad from Minya University, Professor Abada Saeed from Benha University, Ahmed Ali Gouma from Fayoum University, and Professor May Mehrez from the National Hepatology and Tropical Medicine Institute, co-chairing here with me. The liver disease profile in Egypt is witnessing a trajectory shift from infectious predominance in the era of hepatitis C to the metabolic predominance with the era of Mafld. The Egyptian Mafld Research Group, which is a special interested group of academic experts dedicated to the study of fatty liver disease, is emerging to tackle this challenge. In this session, we identified 7 common inaccurate concepts or daily clinical practice. And over the session, we will provide the evidence, but in simple and a practical way to help in correcting these aspects and hopefully ultimately can help in improving our daily clinical practice. So please stay tuned. Now, I'll pass the microphone to my Professor Abada, who will moderate this session.
Bismillah ar-Rahman ar-Rahim. خالص الشكر للاستاذ الفاضل الاستاذ الدكتور سراج زكريا على دعوتنا، والدكتور سراج صاحب فضل عليا. الدكتور سراج ناقشني في الماجستير من حوالي 20 سنه، فبشكره وربنا يبارك في عمره وصحته. Now, this is the guest lecture that will be presented by Professor Muhammad Islam from Australia. Professor Islam is the director of genetics lab at Store Liver Center, University of Sydney. The lecture will be about paradigm shift from Mafld to Mafld.
Thank you, Mr. Chairman, for the nice introduction, and thanks for the organizers, particularly Professor Suraq Zakaria, for inviting me to talk today. So I was asked to talk on the new redefinition of fatty liver disease, but about shift from Mafld to Mafld. Thank you, Mr. Chairman, for the nice introduction, and thanks for the organizers, particularly Professor Suraq Zakaria, for inviting me to talk today. So I was asked to talk on the new redefinition of fatty liver disease, but shift from Mafld to Mafld. So in the overview, I'm going to actually try to touch briefly into 5 aspects with the old terminology, how we came up with the new name, how we came up with the new definition, how this definition moves from a concept to practice, and finally touch very briefly on the future. There are basically 5 major problems with the old terminology that I will try to illustrate. First, the term Mafld does not capture the 90 of patient population with regard to drivers and disease modifiers. In other words, Mafld is essentially a basket. Here we exclude other forms of other liver diseases. Within this basket, patients with metabolic dysfunction are mixed with those with other causes of steatosis, which lead to a heterogeneous group of patients. Will result that we don't have an individual phenotype precisely, with major implications into the development of targeted therapy. Hence, it's not surprising that poor response to therapy and the failures of clinical trials with all drugs approved either failed or just showing a modest effect between 10 to 20%. Perspective, it defines the problem, it discriminates, and brings a whole lot of stigma with it. We need to think about our patient and distance the disease from obesity and alcohol, but on the other hand, it is more closely with other diseases, including diabetes, chronic kidney disease, and cardiovascular disease. As you can see here, there's a whole lot of problems with that. And trying to illustrate for our audience what are the sources of heterogeneity and how it comes up. If we take, for example, the 3 patients, and we look for the sources of this heterogeneity of them. So in patient number 1, the major predominant of the disease are environmental factors with a minimal contribution of the genetic predisposition. While in patient number 3, it's the opposite, with the genetic predisposition as a major player in this patient with a minimal contribution of environmental factors. And patient number 2 is an intermediate between these 2 phenotypes. The lack of the consideration of this heterogeneity will have an impact on clinical trials, have an impact into the daily clinical management of our patients. From a public health perspective, we all know that liver disease is seriously underfunded. Here a study from Barcelona, from Jeffrey Lafayette, is out of 29 countries, there is none of these countries have innovative action plans for Mafld. Mafld is not considered into the screening guidelines for diabetes or other liver disease, and liver disease is seriously underfunded. So with all of that said, do you think Mafld is the right name? So Mafld is the diagnosis of exclusion. It only exists when other diseases are excluded. We need to diagnose our disease using a positive criteria to acknowledge that it can and it actually does coexist with other liver disease with synergistic outcome. There is no safe limit for alcohol intake. There is a negative implication of the current name on patient awareness, public health response, and serious underfunding. And finally, the current one-size-fits-all phenotype seems to be inappropriate and has negative impact on clinical trials. So what was the way to Mafld? We undertake 2-rounded Delphi consensus, which we invited an expert from over the world. In the first round, we asked them to suggest whatever name they think. And in the second round, there was a vote on the top 6 names. And as you can see here, the Mafld or metabolic associated fatty liver disease was supported by the vast majority of these experts. So what others think? As you can see, in just a few months, the new proposal have been endorsed by most of the major societies of liver disease, including Brazil, Middle East and North Africa, Latin America, Sub-Saharan Africa, Malaysian Society, Chinese Society, Spanish, Treat Without Bones, Nurse and Allied Health Perspective, Patient Group Perspective, and Patient Studies. So we said, that's good. So we have now a better name, but how can we define this disease in a positive way to avoid the exclusion definition? Here in a second paper published in Journal of Hepatology, like a year ago, we came up with a simple new definition, which is based on the diagnosis of hepatic steatosis with the presence of one of 3 criteria: overweight or obesity based on the ethnic cutoffs, type 2 diabetes mellitus, and into the lean or normal weight, the presence of at least 2 metabolic dysfunctions. And in a subsequent work, which is in press at the moment, we extended this criteria also for the pediatric, and we developed a new similar criteria that can help into diagnosis of Mafld into the pediatric group as well. Nice. So all of this seems to be good, but it's very conceptual. Does it work into the real life? Actually, as you can see here, multiple studies have emerged and showed that indeed the new criteria of Mafld are superior and more practical than the old criteria of Mafld in identifying patients with a significant fibrosis. Here, a big study using a US cohort and more than 13,000 subjects, reaching to the same conclusion. Another study, we have done it in collaboration with Professor Kawagoshi from Japan. We can show clearly that the Mafld is more superior in identifying patients with significant hepatic fibrosis, have high sensitivity, high negative predictive value.
What about the extrahepatic manifestation? Exactly similarly, here, for example, 2 studies, one in Korean, it's more than 9 million subjects. The Mafld criteria was superior than the Mafld criteria in identifying patients of higher risk of cardiovascular events. Similarly, exactly in more than 13,000 subjects, it was superior in identifying patients with chronic kidney disease. More interestingly, a study led by Professor Yasser Fouad showing that the change from the Mafld to Mafld seems to be helping increasing awareness of the fatty liver disease among the primary care physician and the other specialists. What about the coexistence of Mafld with other diseases? Again, similarly, the same finding was confirmed in chronic hepatitis B, a nice study from Hong Kong, showing the superiority of Mafld to the Mafld criteria in identifying patients with hepatic steatosis, fibrosis, and metabolic dysfunction, with a similar study here from Egypt on chronic hepatitis C. And based on this finding, there is a recent call from international experts into the field of viral hepatitis into the importance of consideration of Mafld into the ongoing effort for hepatitis C elimination, which suggested proposed algorithm for how we should assess for Mafld in patients with cleared hepatitis C virus. So what are the future of this one? So based on this finding, the main first implication will be the ability to undertake a multidisciplinary management for our patients. So we all know that Mafld is a systemic disease that need a group of physicians to work together to improve the care of our patient. Now, with this new definition, our disease become easily to diagnose, coming into the camp with other metabolic diseases, which will facilitate the way for the undertaking a multidisciplinary management. It will also help to undertaking a novel clinical trials, which based on the proper stratification of our patient and the undertaking the appropriate treatment, which is suitable for every group of patients. So in summary, Mafld is a highly prevalent disease that affects a quarter of the global population. So there was a lot of problems with the old terminology. We came up with a name using a consensus process, and we came up with a definition, which seems to be a workable definition with superiority to the old one, which means that for our patient, for our clinician, for research, and for funding, the new definition would be helpful. So our past is rich, our future looks bright, and the history of fatty liver disease is just beginning to be rewritten. And thanks for your attention.
Thanks for Professor Islam for his elegant lecture. Now, and through the answer of 7 sample questions, we will try to clarify a lot of facts about the metabolic associated fatty liver disease. The first question will be answered by Professor Dina Atiyah from Bani Suef University. What is the prevalence of Mafld and what is the level of awareness among patients and physicians?
So the prevalence of Mafld globally is around 25%, and the highest prevalence is found in the Middle East, around 31.8%. Although accurate data is not available about steatohepatitis, however, the prevalence globally is around 1.5 to 6.5%. In a retrospective study performed by the Egyptian Mafld research group from 3 Egyptian tertiary care centers revealed that the leading patient presentation at around was Mafld in 45% of patients in comparison to hepatitis C and hepatitis B. Those patients had higher BMI, higher diabetes mellitus, and higher hypertension in comparison to the other groups. In a survey study performed by the Egyptian Mafld research group revealed that only 4% of physicians were able to differentiate between Mafld and NASH. And the potential seriousness of the fatty liver disease is underestimated as only as 84% of the physicians believe that Mafld can cause very rarely severe hepatic disease. Most of the physicians were aware of that, were GPs. In another survey study performed by the Egyptian Mafld research group revealed that only 30% of patients are aware of Mafld, and only 20% of the 30% will seek medical advice when they have Mafld because they are minimally concerned, in comparison to 90% of patients with HCV or diabetes mellitus will seek medical advice. Those patients were of middle class income, medium to high education, and were of urban residents. And a study performed in Australia revealed that Mafld-related cirrhosis was only diagnosed incidentally by surgeons, GPs, and this is through elevated liver enzymes findings found in surgery or endoscopies. Due to the unmet needs regarding the Mafld in Egypt, our group, the Egyptian Mafld Research Group, found the urgent need for effective education, prevention, early diagnosis, and treatment of Mafld, thus preventing Mafld-related morbidity and mortality. Our role is to evaluate the level of Mafld-related problem in Egypt, to increase the awareness of the public, health professionals, public health authorities, to encourage active policies for early management, thus decreasing the short and long-term public health burden of Mafld and its related complications.
And now, is Mafld just a disease of obese people? Does it exist in non-obese? The answer will be through Dr. Asma Salama, Beni Suef University.
Many people think that Mafld in obese or non-obese or it does not exist. Does Mafld exist in lean patient? About 40% of Mafld population is not obese. Lean Mafld, it is not so benign condition as we think. Many studies discovered that survival-free of liver transplant is lower in lean Mafld patients. Lean Mafld have higher risk for severe liver disease. The cohort was derived from 3 Swedish university hospitals and compromised all patients with biopsy-proven Mafld revealed that obese Mafld had higher risk for overall mortality, while lean Mafld patient had higher risk for severe liver disease. Finally, lean Mafld is in the metabolic adaptation, but more progression in stage of liver disease.
Thank you. And now, is Mafld just fat on the liver and its progression is rare? The answer will be through Dr. Shaimaa Nafadi, Beni Suef University.
US National VHA system published a study in 2018 comparing patients with Mafld to matched control. The risk of HCC was much higher in Mafld patients with hazard ratio 7.6. The chart here showing that Mafld is becoming the first cause of HCC in UK. Number of referrals with HCC is progressively increasing over years to become the most common cause in 2010. A study published in 2016 comparing patients with Mafld to HCV regarding HCC. HCC was less often detected at early stages in Mafld compared to HCV, leading to worse overall survival. However, the two groups have matched survival after adjusting for liver function and tumor stage. Unisi et al. Published a study in 2015 comparing patients with HCV-HBV group-related HCC to Mafld-related HCC. Mafld group has worse percentage of death, up to 61% versus 50%. And Mafld patient also had 5 months shorter survival time than related to viral hepatitis. This chart here showing that only up to 10% of Mafld patients have a curative treatment option, which was less much than for alcoholic or even HCV, and up to 77% of the patients have no treatment option. This study showing that the incidence of non-cirrhotic HCC in Mafld group was much higher than other causes of chronic liver disease, either HCV, HBV, alcoholic, or even idiopathic. A study published in 2018 is pulled estimates from 7 studies indicating that patients with Mafld have had an increased risk of HCC when compared to all other etiologies of liver disease, with a percentage reaching up to 261%. So the risk of HCC in Mafld patients without cirrhosis was much higher for Mafld than other chronic liver diseases. Thank you.
Thank you, Dr. Shaimaa. And now, is Mafld a disease confined to the liver? The answer will be through Dr. Yasmin Gaber, Cairo University.
Considering Mafld is just a disease of the liver is a wrong concept, as Mafld is a multi-system disease associated with a plethora of extrahepatic manifestations and comorbidities. Of these manifestations is the presence of cardiovascular disorders that can range from subclinical heart disease to ischemic heart diseases and arrhythmias. Other associations with Mafld include chronic kidney disorders, osteoporosis, endocrinal disorders as hypothyroidism, obstructive sleep apnea, and the presence of polycystic ovary syndrome, and also the presence of extrahepatic cancers that include colorectal cancers, stomach cancers, uterine, and pancreatic cancers. Most of these extrahepatic manifestations have a well-established association. In this population-based study done on 420 patients with Mafld, and after a 10-year of follow-up, it was shown that survival in patients with Mafld was significantly lower compared to the general population, with the top 3 causes of death in Mafld patients were malignancy, ischemic heart diseases, followed by the development of liver-related complications. Another multinational study done on 458 patients with a biopsy-proven Mafld, either with bridging fibrosis or cirrhosis. This study showed that patients with Mafld cirrhosis present predominantly with liver-related complications, either with decompensation or HCC, while patients with F3 fibrosis present predominantly with vascular events and non-hepatic cancers. Regarding the risk of cardiovascular disorders with Mafld patients, several meta-analyses have assessed this risk. In one meta-analysis, there is an increase in the risk of carotid atherosclerosis in patients with Mafld compared to those without Mafld, with an odds ratio of around 3.7. Another meta-analysis showed that patients with Mafld have an increase in the incident cardiovascular events compared to those without Mafld. Regarding the risk of chronic kidney disorders, these meta-analyses showed that patients with Mafld has an increase in the risk of chronic kidney disease compared to those without Mafld, with an odds ratio of around 2.1. And finally, regarding the risk of extrahepatic cancers in patients with Mafld, this longitudinal cohort study done on Mafld patients after a long-term follow-up of around 21 years, the study showed that Mafld is associated with nearly a 2-fold increase in the risk of incident cancers, with the top 3 causes of cancers were liver, uterine, stomach, and colon cancers. However, it was observed in these studies that obesity alone in absence of Mafld had a minimal impact on malignancy cancer. Thank you.
Thank you, Dr. Yasmin. And now, do we need to screen for Mafld? The answer will be through Professor May Mehriz, National Liver Institute in Cairo.
Thank you. Of course, it's a wrong concept that we shouldn't screen for Mafld, and the proof is that all liver associations and non-liver associations, even the American Diabetes Association, they recommended in their guidelines to start screening in persons with type 2 diabetes. Finding the at-risk patient is the concept of prevention is better than treatment. The fibrosis score and its outcome. As the fibrosis score increases, the outcome worsens, and this is proven in this figure. The outcome could be liver-related or non-liver-related. It might be cardiovascular, other tumors than liver tumors can be worsened with the worsening of the fibrosis. The diagnosis can be now made easily and bedside. It can be by FIB4 or Mafld's fibrosis score. It may give me a clue with low probability or high probability according to the low cutoff or high cutoff. But this is not enough to diagnose fibrosis by these 2 methods. We have to add another more accurate method like FibroScan, or the more accurate, the magnetic resonance elastography, which can even stratify between the simple steatosis, inflammation without fibrosis, and the fibrosis. With normal liver enzymes, Mafld is excluded, or significant fibrosis also excluded? Actually, no. Yes, we encounter incidentally elevated transaminases in patients diagnosed with Mafld, but in 80%, these patients have normal transaminases. And also AST and ALT are not very sensitive for the steatohepatitis or the grading of fibrosis. We all know that with the increase of the fibrosis score or the cirrhosis, the ALT drops. And also it's not very well correlated, AST and ALT ratio with the cirrhosis. It was proven histologically in 2017 that severities of Mafld is the same in both groups, normal and abnormal liver enzymes. The monitoring is according to the baseline diagnosis of fibrosis. If no evidence of fibrosis, the patient will be monitored and followed up during 2 to 3 years. If there is evidence of fibrosis, he will be followed yearly. And if there is evidence of cirrhosis, like any cirrhotic patient, every 6 months, and maybe less than this interval. And please don't forget to screen for hepatocellular carcinoma. We may use non-invasive techniques or scores, transient elastography, and please consider liver biopsy in the gray zone and in advanced fibrosis before the occurrence of cirrhosis and complications. Thank you.
Thank you, Professor Mai. And now the question is, what are the initial lines for management of Mafld patients? The answer will be through Dr. Muhammad Abdullah, National Research Center.
Bismillahirrahmanirrahim. The clue to solve the mystery of Mafld starts by lifestyle modification. According to long-term follow-up lifestyle modification follow-up, good lifestyle intervention reduces all-cause mortality by 29%, coronary vascular disease by 41%, and diabetes incidence by 45%. Weight loss can cause fibrosis improvement, and it also can cause a quality of life improvement. According to the guidelines of American Heart Association, it's recommended a minimum of 6 months high-intensity comprehensive lifestyle intervention consisting of a reduced caloric diet, increased physical activity, and behavioral therapy, followed by a 1-year-long weight loss maintenance program that includes at least monthly counseling with a trained interventionist. Additionally, exercise can have a beneficial effect on reducing fibrosis. Any type of exercise, vigorous and moderate exercise, are equally effective. And there is no difference in efficacy of liver fat reduction by either aerobic dose or intensity. Combined diet exercise strategies are more effective in normalization of liver enzyme levels and reducing liver fat and improving histology. So as the editorial of Easel mentioned, that exercise in Mafld, just do it. Thank you.
Thank you, Muhammad. And now we came to the last question. Do we have a pharmacological therapy for Mafld? The answer will be through Professor Yasser Mahrous, Alminia University.
I am afraid no. Till now, there is no approved by FDA any drug treatment for Mafld. I think Dr. Mahmoud Anis clarified so much this treatment, so I will not make it slow. Vitamin E at a dose of 800 units per day or bioglitazone are used off-label for treatment of biopsy-proven NASH. And we have to remember that the drugs used by many people here are not clarified by evidence. Metformin, ursodeoxycholic acid, statins, and liver support. And the EASL guidelines, all American guidelines also recommend using bioglitazone or vitamin E for treatment of NASH. But remember that both are having some side effects. We have to look for hemorrhagic stroke, prostate cancer, heart failure, overall mortality if you are using vitamin E for a long time, especially at high dose. Regarding bioglitazone weight gain, because of fluid retention, osteoporosis in women, especially heart failure, macular edema may happen. And in very few cases, bladder cancer can happen in patients using bioglitazone. There is now about 200 medications are in phase 2 and phase 3 trials for treatment of Mafld, but till now there is no approved drugs, as we said. And obeticholic acid is now used off-label for treatment of primary biliary cholangitis, approved, but for Mafld it is off-label. The largest trial, as Dr. Mahmoud mentioned, the Regenerate trial found some improvement in fibrosis score, but still we have significant adverse events we should look for. I'm not talking about, but one of the mistakes we are doing is that we use it for normalization of liver enzymes. And as Dr. Mai said, there is no correlation between liver enzymes and fibrosis. Our group proposed the following recommendation when using obeticholic acid, because now it is in Egypt present in a generic form. We recommend as a baseline to assess the degree of fibrosis therapy initiated in patients with fibrosis stage F2 and F3. And we have to assess lipid profile and appropriate history taking of cardiovascular disease. If any, we don't begin with obeticholic acid. Ultrasound for gallstones and appropriate history taking for gallstones and hepatobiliary events or pruritus. And unless there is a strong indication, obeticholic acid should not be recommended for patients with cardiovascular disease, gallstones, or previous hepatobiliary events. And during the follow-up, if we are giving obeticholic acid, we will give for long time. So we have, during the follow-up, concentrate on the following. We have to assess the lipid profile at first, third, 6, and 12 months. And if the patient have elevated LDL, statin should be prescribed if there is no contraindication. If lipid profile fail to return to normal or near normal by 6 months, consider stopping obeticholic acid. We have to assess for fibrosis at 3, 6, and 12 months. If patient fail to show evidence of fibrosis improvement, consider stopping obeticholic acid therapy. And in case of fibrosis regression, we should stop, the stopping point of obeticholic acid is not defined at the moment. And we have to assess for gallstones by ultrasound at 3, 6, and 12 months. If patient develop any hepatobiliary events, consider stopping obeticholic acid therapy. Assessment of pruritus. Dermatological consultation may be needed if indicated. If severe and persistent, consider stopping obeticholic acid therapy. Dear Professor Srag and dear colleagues, I finished by this algorithm as by a Basel guidelines last few months, and summarizing the story of Mafld. If any patient is having steatosis proved by ultrasound, biopsy, or even non-invasive score, we should look for 2 things. If he is diabetic or overweight, we consider him Mafld. And if he is not diabetic or overweight, we look for the 7 metabolic parameters. He should fulfill 2 criteria of the 7 to be considered Mafld. Then I diagnose him Mafld. So I will look for the risk of fibrosis. If he is at low risk of fibrosis, this patient I consider follow him up every 2 to 3 years. And if he is at the high risk of fibrosis, he should be either intermediate or severe. If he is severe, I think he is cirrhotic and liable to hepatocellular carcinoma, so I will consider follow up him as a liver cirrhosis and hepatocellular carcinoma by regular screening by ultrasound alpha-fetoprotein. If he is in the intermediate risk, this is the gray zone, I may consider doing a liver biopsy in this case. And then according to the guidelines, I may give him lifestyle modification, bioglitazone, vitamin E, and recently, if he is liable to be treated by obeticholic acid, I will treat him. Thank you. Thank you, our dear Professor Srag, for allowing us to be in this very eminent conference, and we are considering you our teacher, our father, our eminent professor.